Dr. Waserman is an assistant professor in the Department of Medicine and Dermatology. He completed his medical school and MBA program at McGill, and then residency in dermatology at both McMaster and Toronto. He joined us with a practice in the Bourse Clinic. He does contribute to undergrad, postgrad training, and he is interested in contact dermatitis, and he runs the McMaster Allergy and Dermatology Patch Test Clinic. Today, Dr. Waserman is talking to us about mastering inpatient dermatology cases, sorry, inpatient dermatology mystery cases. Talking about mastering. I'm hoping to master dermatology by end of today, you know, but I'll probably just focus on solving some mysteries along with Sam. Excited to hear about dermatology more, and Sam, great work. So Sam, without further ado, I'll pass it on to you, and then we'll have a discussion at the end.
Thanks so much, Dr. Zam, and I'm also hoping to master dermatology one day. Thank you for inviting me to present. And I called this dermatology mystery cases because I hemmed and hawed over what to present until the very end. Actually, I even swapped out a case yesterday because I thought something would be sort of higher yield. And initially I had planned on presenting 3 or 4 cases. You know, of course, I ran it by my, role model and mentor, my mother, who's an allergist here, as you know, and she told me that it was way too long. So I just cut it down to 2 cases. The first one is relatively straightforward, but I think in terms of the differential is very high yield. And the second one is exponentially shorter. And I'll just keep close track of the time to make sure I don't go over. So this is called McMaster Inpatient Dermatology Mystery Cases, and this is actually on the front here. This is not a picture of dermatographism, but rather it's a flagellate dermatitis that a person developed after consumption of bleomycin. So you only really get this with either bleomycin or undercooked shiitake mushrooms. So I thought it was neat. Just the land statement. We're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. So the objectives are to develop an approach to dermatologic conditions seen in inpatients, to distinguish between clinically similar entities, and to discuss treatment of the above dermatologic conditions. Case number 1. So a 42-year-old man admitted to the Juravinski Cancer Center with erythroderma, a 1-week history of a worsening whole body pruritic eruption. As the rash worsened, he felt more fatigued, unwell, minimal intake. He was afebrile. There was no mucous membrane involvement. He suspected it was his Irish Spring body wash that he had started to use a couple of weeks prior. The only medication he had been on was started 5 months prior, bisoprolol, a beta blocker. No dose adjustment since, no medications or supplements, no exposures, travel or medications, no infectious symptoms. Aside from the, fatigue and quote unquote feeling unwell, no constitutional symptoms. Review of systems was otherwise unremarkable. His past medical history was significant for hypertension. He had long-standing, what he called dry skin on his extensors, in particular on his elbows and knees, for which he had used, quote unquote creams. His mother had a diagnosis of atopic dermatitis. Again, his only medication was bisoprolol. He didn't have an allergy to any medications, no history of atopy. He lives alone. He's had been employed with the same company doing the same thing for the last 8 years, packing boxes, consuming 5 beers a day, and he has private insurance. So this is what we see here, and this is not his whole body. Really only allowed me to take 1 picture, so that was it. But even here, we can appreciate, you can see the rather diffuse erythema and scale, and you'll be seeing more in the coming slides. So what is erythroderma? Now, erythroderma is sort of a like catch-all phrase where a patient has pretty impressive redness, but actually what it means is it means widespread erythema involving at least 90% body surface area. And when I have to admit that when I hear erythroderma, I start to get, palpitations because immediately my mind turns toward Exhibit A, which is TEN, or toxic epidermal necrolysis due to allopurinol. But in fact, it can be even less common presentations, such as the deck chair sign that's seen in papuloerythroderma vafuji, which is a unique entity. It's most commonly seen in Japanese men, and they get these sort of reddish-brown, generalized pruritic reddish-brown papules, which evolve into erythroderma. And it's called the deck chair sign because it spares the skin folds. Now, this is not only associated with papuloerythroderma vafuji, it's also been associated with dermatomyositis and mycosis fungoides and others, but I just thought it was neat. So in terms of broad categories for causes of erythroderma, these are them. So we think of inflammatory conditions, medications, neoplastic disorders, autoimmune disorders, infection, congenital disorders. I could talk about erythroderma for hours. So I'm only going to ramble on about a few select topics. And of course, if you have any questions at the end, I'm more than happy to answer them. So what are the possible systemic complications of erythroderma? And there's many. So thermoregulatory disturbance, either hypo or hyperthermia, tachycardia, high output cardiac failure, peripheral edema, generalized lymphadenopathy, especially if we're talking about entities like Sézary syndrome, electrolyte disturbances, anemia, hypoalbuminemia, hepatosplenomegaly, sepsis from colonization. There's many. So what are the most common causes of adult onset erythroderma? Well, dermatitis, especially atopic dermatitis and contact dermatitis, though there are others as well, such as seborrheic dermatitis and chronic actinic dermatitis. They can also cause erythroderma, psoriasis, medications, CTCL, and most commonly idiopathic, which is 30%. Some sources say even as high as 50%. So now we'll talk about some inflammatory disorders, and I'm going to talk about erythrodermic psoriasis. So erythrodermic psoriasis is the least common form of psoriasis. It occurs in all ages. And these patients usually have a history of psoriasis. This is less often the first manifestation of the condition. The onset can be gradual, so either the progressive worsening of an existing disease, or it can be acute. And as such, it's important to screen for triggers. Now, I want you to look at erythrodermic psoriasis on the left and plaque psoriasis on the right. And we see that in erythrodermic psoriasis, the erythema is quite striking, but it's not as the scale is not as thick as it is in plaque psoriasis, for example. And we see these sort of well-circumscribed psoriatic plaques in a classic presentation of plaque psoriasis. So if you're like me, you still sort of operate with mnemonics, but you can't seem to remember comprehensive lists. So there's actually, most of those mnemonics, though, are not really worth very much. This is actually a very good one, or one at least that I think is very good for triggers for psoriasis. So the mnemonic is pitted nails. So psychogenic stress, infections, most commonly HIV, strep pharyngitis, impetigo, trauma, the Kebner phenomenon. And actually, I put two manifestations of the Kebner phenomenon on the right. The top picture is actually a patient who had guttate psoriasis, and then had a nasty sunburn, and then proceeded to Kebnerize, develop psoriatic plaques in areas previously unaffected. So it's the Kebner phenomenon is a traumatic induction of psoriasis on non-lesional skin. And then we also see the Kebner phenomenon in the bottom picture in a patient who developed or who had shingles. So they actually developed psoriatic plaques on top of where they developed the shingles, which I thought's neat. Now, the Kebner phenomenon is not exclusive to psoriasis. We also see it in entities like lichen planus and vitiligo, for example. Going back to the mnemonic, so terrible habits is the other T, so smoking and alcohol. Endocrine, pregnancy, obesity, hypocalcemia, and the mechanism for that is not exactly known. It's thought that that hypocalcemia damages the cadherin proteins, those cell adhesion molecules. And last but not least is drugs or medications, and that's the mnemonic for that is NAILS. And so NAIL stands for NSAIDs, antihypertensives, so specifically ACE inhibitors and beta blockers, antimalarials, antifungals. The I is interferon, imiquimod, infliximab. L is for lithium, and the S is for steroid withdrawal, specifically the abrupt cessation of steroids. And I'll talk a bit about the von Zombush variant of generalized pustular psoriasis, which you can often see with the abrupt cessation of steroids. So that's the von Zombush variant of pustular psoriasis, which, as I said before, can evolve into erythroderma. And on the left here, you see sort of these sterile pustules on a background of erythema. And then once it's evolved into erythroderma, a lot of those same pustules have been lost. And we see sort of this rapid and generalized painful skin, fever, leukocytosis, low albumin. It's been associated with hypocalcemia and also with the abrupt cessation of steroids. Now, with drug-induced psoriasis, similar to drug reactions, it's really, really important to make up a drug timeline. So you can better try to figure out, what may have been responsible for the exacerbation of the psoriasis. Unlike drug eruptions, I should say, in drug-induced psoriasis or exacerbated psoriasis, it can be, up to a year or longer. So not quite akin to ACE inhibitors and angioedema, but still quite long. Typically, we tend to ask about 1 year's worth of medications. Terbinafine and NSAIDs typically are less than 4 weeks. More on the intermediate spectrum, 4 to 12 weeks, are antimalarials and ACE inhibitors. And then lithium and beta blockers tend to be more than 12 weeks. Now, if there's any uncertainty as to the diagnosis, a biopsy can be helpful, and you would expect to see a dermal eosinophilic infiltrate and a lichenoid pattern, but the absence of these features doesn't exclude the possibility of medication as a trigger. Now, some helpful clues on history and physical exam. With history, it's important to screen for a personal or a family history of psoriasis. Now, they may not refer to it as psoriasis. They may refer to it as eczema. They may refer to it as something else. It's important to try to tease out the distribution of their skin lesions, maybe look at pictures and symptoms. Always important to screen for psoriatic arthritis. So I typically ask about joint symptoms, low back pain, and morning stiffness. If so, how long? Is it better or worse with activity? And then physical exam, plaques affecting the classic site, so the extensors, most commonly the elbows and the knees. And then also important to look at the nails. Now, pitting is not very specific. You see pitting there on your top left. It's also seen in alopecia areata and eczema, but it is important and would help, would lead you possibly in the direction of psoriasis. I want to draw your attention to the oil drop sign, so the top right picture there. That's the most that's virtually pathognomonic for psoriasis. So you see that like translucent, yellow-red discoloration beneath the nail plate. So if you see that, you can be certain that this is psoriasis. And then for completion as well, the bottom right-hand corner, there's some subungual hyperkeratosis, which is seen in psoriasis. It's also seen in infectious entities like onychomycosis. And the same goes for the bottom left, where you see that nail plate crumbling. Now, in terms of treatment of erythrodermic psoriasis, it's important to admit for supportive therapy if necessary. And as mentioned before, it's important to search for reversible causes. So medications, infections, hypocalcemia, recommend bland emollients, typically would recommend a mid-potency topical steroid to start, and this is until the diagnosis is known. So what's available on HHS formulary is full-strength beta-derm ointment applied to, which you can apply rather diffusely and liberally 3 times a day. In terms of systemic treatments, there's acitretin and cyclosporin are most commonly used. With cyclosporin, typically I like to start very high at 5 milligrams per kilogram per day. Infliximab as well. And again, systemic steroids should be avoided because of the risk of a rebound erythrodermic flare and exacerbation of the disease. But it is important to note that in some instances, it's really the only thing that works. And it's also the only thing, or one of the few things rather, that's indicated in should erythrodermic psoriasis or generalized pustular psoriasis occur in pregnancy. So that's just something important to keep in mind. So now I'm going to talk about very, very briefly, we're just going to look at some pictures. Pityriasis rubra pilaris. Now, this is not an adult patient. This is an 11-year-old girl who was admitted here last summer. And she presented sort of with this diffuse sort of orangish red eruption. And she had, I don't know if you can appreciate what they call here, the buzzword is a Branny scale and a follicular accentuation of the scale. And then I want to draw your attention as well to this sort of waxy orange plantar keratoderma. It was actually a palmoplantar keratoderma. So something important to keep in mind in this case actually was trauma-induced playing on her driveway, which is unfortunate. She made a full recovery topically with topical steroids and calcineurin inhibitors and vitamin D analogs. So I'm just going to skip over other inflammatory conditions, and I want to go to something called an autoexematization reaction or an ID reaction, because it's something that's often missed or under-recognized. So an ID reaction or autoexematization reaction is a secondary, where secondary eczematous lesions develop days or even weeks after and distant from the primary exposure site. And typically this is a result of an allergic or irritant contact dermatitis. In older adults, stasis dermatitis is more often implicated, and less often tinea pedis. In people who have 2 of those things, so allergic contact dermatitis and stasis dermatitis, for example, 2/3 of them can evolve into an ID reaction, and basically it will just look like a diffuse sort of eczematous eruption. So it's really important to take a history to find out what had happened, because you have to treat the underlying cause. Otherwise, it will just simply get labeled as atopic dermatitis. And I'll give you an example. I saw someone in clinic a few months ago, or several months ago rather, who developed a diffuse eczematous eruption on her whole body, required systemic steroids. She came to me and we started talking about how it evolved, and she actually had started, the plaques had started on her shins, she was in her church's traveling choir group. She developed eczematous, well-demarcated eczematous plaques on her shins after she had worn new neoprene stockings. So I patch tested her. She had an exuberant reaction to the neoprene in her stockings. So she developed an id reaction following a contact allergy to her stockings. Anyway, she's well. So here's my shameless plug for how we perform patch testing at the Boris Clinic. Essentially, it's 80 reagents, 80 haptens rather, put on one's back, and we have everything from this. It's the Chemotechnic 80 series, and we have preservatives, fragrances, textile dyes, rubber accelerators, all sorts of things. So if you suspect an allergic contact dermatitis and the patient would like to get tested, certainly refer them. We're more than happy to see them. So now, causes of erythroderma, medications. I'm not going to talk very much about this simply because we had that excellent presentation from Dr. Fahmy previously, and I feel like this is something that's constantly presented on. But just to briefly touch on a few things. So we see on the left the drug hypersensitivity syndrome. So typically fever, hepatitis, nephritis. We see a serum sickness-like reaction, fever, urticarial, rash, arthritis, high fevers at that, and angioedema. AGEP, typically fever, generalized pustular eruption with a high white blood cell count. And then there's SJSTEN, Stevens-Johnson syndrome, and toxic epidermal necrolysis, which, as we all know, is a spectrum of blistering eruptions, typically extensive mucosal involvement, skin sloughing, necrosis, hemorrhagic crusting of the lips, and the like. I'm just going to talk about neoplastic disorders now, specifically cutaneous T-cell lymphoma. So mycosis fungoides, or MF, accounts for 50 to 70% of all primary CTCL cases. Sézary syndrome accounts for less than 5% of all primary CTCL cases. And Sézary syndrome is characterized by erythroderma, peripheral blood Sézary cells, and generalized lymphadenopathy. Sézary syndrome can sometimes be preceded by MF, other times not. And they actually clinically are nearly identical, but erythrodermic MF has very few or no circulating Sézary cells in the peripheral blood, and I'll talk about the classification very shortly. So diagnostic clues to CTCL. Now, this is important because oftentimes this can look very much like other, I know this is not erythroderma, but I wanted to segue to this as well. If an inflammatory skin condition, what you think is, psoriasis or eczema or psoriasiform dermatitis or small plaque parapsoriasis or what have you, is not behaving like that, it's not responding to our usual therapies at all, perform a biopsy, and you may actually require multiple biopsies to catch it, because CTCL is very difficult to biopsy, and oftentimes the biopsies don't really come up with, it just comes up with something non-specific. But the way CTCL presents is these sort of persistent patches and plaques in photoprotected sites. And where they're on the head and neck, they can be indurated, and there they also tend to have this accompanying what they call a cigarette paper type scale. And they can start out as they can be patches or plaques, and then they can evolve into generalized nodules or tumors, ulcerations, and necrosis as it becomes more advanced. And then rarely can it evolve into erythroderma. This is one instance, actually, that's we saw it. This is not from Hamilton Health Sciences. We saw this at Sunnybrook during residency. This is erythrodermic tumor stage MF, and you can actually see the tumors here. And this is a patient who was sent initially who had biopsies reading psoriasis or what have you. It's a very, very bizarre story. But if you look at this presentation as well, I mean, you could think, for example, this was a drug eruption, or perhaps some sort of, B-cell lymphoma, or a deep fungal infection, or carcinoma cutis, or maybe grasping at straws. So diagnostic clues for Sézary syndrome: intense pruritus. So I don't usually recommend sedating antihistamines very often, but oftentimes it's the difference between sort of sleeping and functioning and not. The skin is often infiltrated or hyperpigmented, what they call melanoerythroderma. They have this painful fissured palmoplantar keratoderma. So that's in contrast to PRP, where it's sort of this waxy orange. This is extremely painful, and the fissuring is quite pronounced. They have the leonine facies that you see as well, and that's not exclusive to Sézary syndrome. It's seen in a whole host of conditions as well, like lepromatous leprosy, amongst others, and diffuse alopecia. So here's the diagnostic criteria for Sézary syndrome, for just simply for completion. So at least 1,000 Sézary cells per millimeters cubed, a CD4 to CD8 ratio of at least 10:1, and an increased percentage of CD4 positive cells within an abnormal phenotype. Now, in terms of the workup for CTCL, it's important to screen for constitutional symptoms, a full body skin exam, including lymphadenopathy and hepatosplenomegaly. You see all the serology there on your screen that we typically screen for. If you're concerned for Sézary syndrome or tumor stage MF, we recommend a pan-CT. And as I said before, multiple biopsies in at least 4 to 6 millimeters. So this is one instance where, doing a single 3 millimeter punch biopsy will not, may not be as useful as multiple larger biopsies. And then you tick off as well to send for the lymphoma protocol as part of the specimen collection within EPIC. I'm not sure if that's how it is within Dovetail as well. And it can look like many other inflammatory conditions, so it's really important to send it for immunohistochemistry and T-cell rearrangement studies. And then referral to the Juravinski for management if once the diagnosis is confirmed. So as I said before, this is the staging for MF. The difference, and I've put in bold there, the difference is what sort of determines whether or not something is one stage or another stage, or A or B within the same stage. So most commonly what I see is patch and plaque MF. So either 1A or 1B, depending on the amount of body surface area. But they have multidisciplinary clinic at Juravinski that deals with all of these stages. So once you have nodal enlargement, that's when you're in stage 2A, and tumors is 2B, and heavy blood involvement is 4A1, and that's the threshold for Sézary syndrome. So just to be brief, treatments for CTCL, and this is not a inclusive list, a comprehensive list rather: topical corticosteroids, retinoids, chemotherapy, imiquimod, radiation therapy, phototherapy, photopheresis. So just briefly, talking about autoimmune disorders, specifically, I just want to touch on for a second pemphigus foliaceus. So this is pemphigus foliaceus. Pemphigus or pemphigoid rarely and this is a very benign form of pemphigus, very rarely evolves into erythroderma. But you see here these sort of superficial and fragile, oh, there's my mouse, superficial and fragile blisters that lead to these sort of widespread crusts. And then you see these erosions here as well on a background of erythema. Scale is everything in dermatology. This is actually called cornflake type scale. That's the buzzword for pemphigus foliaceus. A Branny scale was pityriasis, was PRP. Micaceous scale within psoriasis. This is cornflake type scale. Anyways, these patients tend to do very, very well on steroids and steroid-sparing agents. Infections. So this is crusted scabies. This is actually a patient that I saw when I was an elective medical student, and this is the CCU at Hamilton General, and the referral was for psoriasis recalcitrant to traditional therapies, and this has a very distinct what they call a powdery scale. Anyways, this is crusted scabies. Unfortunately, this patient passed away. So putting it all together, in terms of the history, so a complete history, past medical history, medications, allergies, etc. Personal and family history of dermatologic conditions, so names of diagnoses, if they don't remember that, distribution, any new products they used, drug history, medications, not only prescription ones, but also over-the-counter, natural products, most common medications, allopurinol, various antibiotics, NSAIDs, anticonvulsants, contrast dye. And I can't underscore the importance of making a drug timeline. We had a patient who was sent to us for an opinion on erythroderma, and then I had a medical student with me who called the pharmacy, and she spent 45 minutes making a drug timeline. And the patient, her erythroderma had been attributed to some obscure antibiotic, whereas in fact she had been on allopurinol. So I'm just taking the time. I know that everyone is very, very busy to make that timeline, and then liaising with the pharmacy, with the family, and with Clin Farm, depending on what site you're at. Prodromal symptoms of fever, sore throat, malaise, constitutional symptoms. So I didn't touch on this before, but you asked them about history of cold sores, specifically thinking about HSV, which accounts for 90% of erythema multiforme. Cough, thinking about mycoplasma pneumonia, which is also a cause of EM, but also other things as well, like mycoplasma-induced rash and mucositis. Any recent travels, are other contacts affected? History of atopy, history of venous stasis, thinking about those id reactions. Full body skin examination. So on physical exam, full body skin examination, including lymphadenopathy, and checking for hepatosplenomegaly. With PRP, another thing that we see as well, which is not exclusive to PRP, but we see these sort of islands of sparing. And look for facial edema, which is seen in drug hypersensitivity syndrome. Try to pay attention to the scale if you can. So if it's exfoliative, like an exfoliative dermatitis or peeling, think of drug reactions. Powdery scale, crusted scabies, Branny scale, pityriasis, rubra pilaris, a micaceous scale, sometimes seen in psoriasis, but sometimes lost if they progress to erythroderma. And again, that palmoplantar keratoderma that I talked about, sort of red, orange, waxy as in PRP, more painful and fissured in Sézary syndrome. The nail changes that I talked about, so the oil spot being the most specific for psoriasis, and alopecia, the diffuse non-scarring alopecia seen in Sézary syndrome. Investigations, which you see here on your screen, a lot of which I've already covered. I added on as well. I can talk about, atopic dermatitis, IgE, and of course you would look for, eosinophilia on the CBC. I'm often asked about biopsies and sort of where to perform them and such. So as I talked about before, CTCL, the 4 to 6 millimeter punch biopsy for H&E, and because, as I said before, it can look like many reactive conditions, so you need to send it for immunohistochemistry and T-cell rearrangement studies. For immunobullous diseases, if you could send it from a blister edge, doesn't have to be anything substantial, 3 to 4 millimeters in formalin, and then also perilesional from normal skin for DIF and Michel's media. Now, I say from normal skin, but it's actually right next to erythema. Completely unaffected skin would be something like for dermatitis herpetiformis. If it's a small blister, if you could actually do a more sizable biopsy, it would be great if you could get the entire vesicle and sort of the background, background erythema, if there is any. That would be the highest yield. But generally, blister edge and a fresh lesion, fresher is better. Blister edge for histopathology in formalin, perilesional for DIF in Michel's media. The Michel's media is critical. You have to call pathology and they'll deliver it. So treatment, just this are very broad strokes here. This is not specific, but low threshold for admission. So correction of fluid and electrolyte imbalances, oral antihistamines for pruritus with accompanying mid-potency topical steroid ointments, liberal use of emollients, and then again, other treatment options depending on the etiology. So back to our case, he was biopsied. I sent them stats. To my amazement, we got them back in 72 hours. He had been slathering on Betaderm ointment 3 times a day with some Glaxol base. His blood work looked pretty good, actually, except his liver enzymes were elevated. And then he had fatty liver disease as well. Anyways, he ended up leaving AMA and he was completely lost to follow-up. I did, however, touch base with his family doctor when we found out the results of the biopsy, which showed classic features of psoriasis. And there was also that dermal eosinophilic infiltrate. Now, in this case, it was rather straightforward, not straightforward, but it was easy. He wasn't on a million medications, so there was no speculation. So the family doctor switched his beta blocker to an ARB and asked for the family doctor a few months later. He cleared. I'm not sure if that was back to sort of his baseline dry skin, or if in fact he was fully clear. So that's, and I should also mention the GP confirmed that he had long-standing psoriasis. So something that we speculated, and he had, and it was hard to tell what his sort of baseline level of disease was when we saw him initially. So now I see I don't have a ton of time left, so I'm just going to go through this case. And this is someone who I actually just saw. She was sent to me. She was admitted to Juravinsky Hospital. She's a 55-year-old woman with stage 4 adenocarcinoma of the esophagus and the GE junction, and she was admitted with a 1-week history of a worsening, painful purpuric eruption. It started 5 days after exposure to NSAID, which was being used to treat an MSSA bacteremia. To make things more complicated, prior to that, she was on Piptazo. And then to muddy the waters even more, she had been enrolled in a clinical trial at PMH, whereby she was on a checkpoint inhibitor, and then she developed a hepatitis and a pancreatitis. So she was put on very, very high doses of steroids. And the skin lesions appeared while she was tapering her prednisone. She was on 10 milligrams on the day of the appointment. She hadn't been on the trial medication for at least 2 weeks. The notes, we tried to put together the medication timeline as best we could. But it was not, the notes and the timeline were not, it was very, very difficult to piece together. But importantly, when we saw her, she was no longer on the three culprits that we could pinpoint. So those being the NSAID, and that was sort of our number one, the Pip/Tazo, or the clinical trial medication. I should also mention she was seen in hospital by internal medicine, who consulted ID as well, just in the context of her MSSA bacteremia, and she got a top of the line workup where they worked her up for everything under the sun. Importantly, in this instance, it's also important, one should mention that the workup for autoimmune connective tissue disease was negative. She wasn't on any other medications. No other relevant, I mean, there's all sorts of complications with regard to her malignancy, but nothing relevant to this. No other medications or allergies. So this is her presentation, and it's really quite striking. So she was, so here are her legs, and I actually zoomed in on, so typically this is on the lower extremities. It's palpable purpura, and these are actually bullae. So bullae, on a background of these painful, palpable purpura, she was extremely edematous, in a lot of pain. And my concern was, I mean, we did biopsies and such, but at this point I was thinking to myself, I really hope she doesn't ulcerate, because she was quite edematous. So this is a cutaneous small vessel vasculitis, likely bullous leukocytoclastic vasculitis. And it's a type of cutaneous small vessel vasculitis that's characterized by palpable purpura on the shins, approximately 1 week after the inciting factor. It can be rather diffuse. So though it's concentrated on the lower extremities, it can be on the arms, legs, trunk, as it was with her. When advanced, you can have edema and bullae, as was the case with this patient, with accompanying ulcers. It can be painful or itchy. In her case, as I said before, it can be, it was very tender. So these are all of the causes of a leukocytoclastic vasculitis. So hepatitis B and C, strep, URTIs, Neisseria, and you see the other autoimmune connective tissue disease medications, neoplasm, idiopathic. Now, medications, just with the timeline and also being a classic culprit, we thought it was Keflex, or we thought it was IV and CEF, but really all of them are possible. And, you know, with regard to the neoplasm, nothing had really changed. Typically, it's hematologic malignancies associated with an LCB. And she had been dealing with her malignancy for years, so that was less likely to be the cause. And if there was nothing to pin it on, idiopathic. But she's doing a lot better now, having stopped the IV NSAID and switched over to daptomycin. So it's important to screen for infection, inflammatory conditions, malignancy, autoimmune connective tissue disease. Fresh biopsies are critical. And unlike vesiculobullous disease, in this instance, when you're biopsying a vasculitis, you want it to be lesional. So this is a lesional biopsy for DIF, or direct immunofluorescence. Remember, we put that in Michelle's. And also for H&E. So we did multiple biopsies. They're still pending. And the serological workup you see below, looking for all possibilities. In terms of treatment, so you want to treat any infections, make sure that underlying conditions are stable, and stop any offending agents. So there's mild or skin-limited disease, which is leg elevation, compression stockings, NSAIDs, antihistamines, topical steroids. Chronic or severe disease, there's dapsone and colchicine. And then severe ulcerating disease is steroids, 1 milligram per kilogram, tapered over 4 to 6 weeks, azathioprine and methotrexate. So all possible medications had been stopped. As I mentioned before, her daptomycin was switched to or her IV NSAID was switched to daptomycin. So what I recommended to the team was pulse solgumedrol. 125 milligrams IV Q daily for at least 3 days. And I when I spoke to the residents, because they were kind enough to that patient was kind enough to come see us at the Boris, was ensure that the progressions of the lesions have stopped. Otherwise, I would have recommended the full 5 days. But thankfully, after those 3 days, the progression of the skin lesion stopped. And I recommended a prednisone taper of 50 milligrams daily for a week, and then tapering by 10 milligrams each week. Also, while she was admitted, I recommend, because of the extent of her skin lesions and edema, I figured IVIG just as an adjuvant, pretty benign treatment, 1 gram per kilogram. Again, it's ideal body weight per day for 2 days. And then also, speaking of, adjuvants do no harm, colchicine, which I started at 0.6 milligrams twice daily, and I'm going to be seeing her in follow-up tomorrow. Thank you.
Thank you, Sam, for this fantastic overview of 2 interesting cases. At least one of them is very scary at times, when you see it. I'm gonna open the floor for questions. We really appreciate the presence of dermatology expertise, especially on these cases when they show up on the wards, or we see them in our outpatient practice and bring them in to see you and see others. We've been, as you're aware, struggling in Hamilton to get a strong plan for inpatient consults, and I think we're getting there. I don't know if everyone knows that we are actually into our 4th dermatology recruit. Hopefully she will be joining us soon, and hopefully then we'll be having a regular roster. But I know a lot of the attendees today's questioning is like, what would happen if they're on the wards and they have a patient that needs to see you or see a dermatology with your expertise? How do they reach out to dermatology nowadays?
Probably the best way is over Epic, and I mean now. One of our colleagues was away on leave. Dr. Pathiapura and I were covering. So if one of us, we would assign sort of 3 weeks on or 4 weeks on, 4 weeks off. And so if one of us was on call at a particular time, the other person, we could receive messages over Epic. St. Joe's is more difficult. Hopefully the practitioners at St. Joe's have Epic access, but that's probably the easiest way. And then I speak to people in all departments at the hospitals regularly. And they send me pictures over Epic, and I give them advice. And even if we can't necessarily see them in hospital, we make plans for follow-up. And there have been instances even where I've provided advice through pictures and talking on the phone, and I've done that throughout a patient's admission. So it's like an amazing era we live in, but it's been a perfect storm in the sense that 3 or 4 seasoned dermatologists in Hamilton have retired in the last 3 to 6 months. And, one of our dear colleagues was on a leave, but I mean, that part is sort of stabilizing. And hopefully, as you said before, someone is coming on in the next month or 2. So hopefully there will be some stability.
Yeah, I absolutely think that, by early in next calendar year, probably maximum by the academic year, we will have a stable roster for on-call for both hospital systems, both Hamilton Health Sciences and St. Joe's. So stay tuned. Probably we're coming into our best days of dermatology in the Department of Medicine at McMaster and Hamilton Health Sciences and St. Joe's. So things are looking good. If you have any question, please add it to the Q&A, or if you want to come in to speak your question, please raise your hand. Looks like, Sam, having a skin biopsy is a key part of much of those diagnoses, and a lot of our colleagues on medicine, love to do them. Dr. Ahmed has pointed out that it's at times difficult really to locate skin biopsy I'm assuming you have them in your pocket when you come in here and you do them on the wards. Any secret skills to find a skin biopsy in Hamilton Health Sciences wards? I have some ideas, but what's your trick?
To be honest with you, I put the materials in a specimen bag from the Boris Clinic and I take them to the hospitals.
Yeah, that's your trick. That's what I expected. You have them in your pocket.
Very high tech. Yeah.
I just want to assure people, at least at Hamilton General, actually, our chief medical resident, Dr. Haddad, is actually going through a QI project where she wants to create a procedural cart for internal medicine. So I will work with her, make sure that there are some skin biopsy needles, as well as the punch biopsy needles, as well as the material to hold those samples to ensure that it's easy to do these procedures because they're entirely diagnostic. Amna has raised her hand. Amna, you can come in. I don't know how to get you in, but I'll try. Allow Mike. You are in, Amna.
Yeah, thanks so much, Khalid, and thanks so much, Sam, for that great presentation. The other thing I was going to add is because part of the challenge is some of the samples and some of the testing. Like I think like the basic pathology we can do locally, and you can put those orders in Epic, but for any additional testing, like immunofluorescence, my understanding it goes externally, so you actually have to fill out a separate requisition, and it becomes a whole kerfuffle while you're doing the biopsy. Where do I find the rec? I found the easiest thing to do is to walk down to the pathology lab, but that's not always feasible. So even if we could make it easier to maybe have some of those external requisitions available, and where to find the formal, and it's simple things like even if you find the biopsy kit, you can't find the media to put it in for immunofluorescence, and then you have to find the requisition. So I don't know if there's ways to make that a little bit more streamlined and available for everyone, because it does become a resistant for people doing the biopsy, because it just takes up so much time to do all of the gathering rather than the biopsy itself.
Yeah, look, point well taken. I wholeheartedly agree with you. With regard to the forms, we can actually get them off the Life Labs website. There is under Life Labs. I simply printed out dermatopathology requisition forms. I printed out a bunch and I just fill it out there. And just ensuring that the specimen is kept inside a fridge. It can be kept there for 5 days. And the Michels, there's actually Michels in the pathology lab at all sites, apparently. And when I was at Juravinski in June, and I forgot the Michels, my infinite wisdom, they were actually able to shuttle it over from Hamilton General to Juravinski, and they had it within 45 minutes. I was shocked. So there are ways, but they're usually pretty well stocked at the various sites.
Thank you, Amna. Thanks, Sam, for that comment. I don't see other questions. I have a question about a small vessel vasculitis, leukocytoplastic vasculitis, and medication. So you try to stop all the culprit or possibly culprit medication, but however, at times you can't stop them. So would you occasionally consider treating and hoping that they would do better on the risk medication that may be causing the vasculitis, or do you always eliminate every possible medication that could be contributing? Especially that, this has been reported with, the list of medications you put are common, but literally with many other medications that we use right now.
Yeah, no, you bring up a very good point. Everything is a risk-benefit analysis. And though I haven't been in a situation where we've had to, at least for a small vessel vasculitis, have to keep the culprit medication on board and treat the vasculitis. You certainly could. The case that I presented was sort of severe borderline ulcerating leukocytoclastic vasculitis. Most of the stuff I see is very run-of-the-mill, a very mild skin-limited disease. So, it would be possible to treat with one of the agents like colchicine, for example, or methotrexate or IVIG or dapsone, depending on the circumstances. But yeah, everything's a risk-benefit analysis.
Fantastic. Thank you, Sam. I don't see any further questions or comments. I really enjoyed, and I think I'm a little better in dermatology right now than at the beginning of the hour. So I have not achieved mastery, but I've at least acquired some knowledge into a very important topic. So I have some comments here. I don't want to miss anyone. Very informative, Sam. Thank you. Great talk. Agree. People are commenting just positive comments. So thanks, Sam. I think everyone have enjoyed this, had great attendance and great discussion. Thank you. And I appreciate your time and your expertise and the care you provide to our patients. And a reminder to fill the survey that comes out shortly after the rounds for everyone, because that feedback is important to us as a department as well as to our speakers. Thank you again, Sam, and have a wonderful afternoon, everyone. Thank you.
Thank you very much.